welcome to our video on lung neoplasms. Let's get started. Here's an overview of what we'll be discussing in this lecture. We'll be covering primary lung cancer, solitary pulmonary nodules, mediastinal masses, and lung cancer screening. Let's start with primary lung cancer. With regards to primary lung cancer, we'll be discussing classification, risk factors, clinical presentation, diagnosis, and management. Let's start with classification. Lung cancer is the leading cause of cancer-related deaths in the United States. It's often divided into two subtypes: non-small cell lung cancer, accounting for approximately 75% of diagnosed lung cancer, and small cell lung cancer, accounting for the remaining 25%. Distinguishing between the two types is important as the management significantly varies according to the type. Here is a table that combines the two types of lung cancer along with their most important identifying features. Let's first start with non-small cell lung cancer, or NSCLC. As we previously mentioned, non-small cell lung cancer is more common than small cell lung cancer and is considered less aggressive and has less tendency for early metastasis. It has multiple histological types, including adenocarcinoma, squamous cell carcinoma, large cell carcinoma, and bronchial carcinoid tumor. Adenocarcinoma is the most common type of non-small cell lung cancer and is usually found peripherally. It's also the most common type of lung cancer in women and non-smokers. On imaging, adenocarcinoma can resemble pneumonia, with a chest X-ray showing hazy infiltrates. This type of tumor contains mucin-producing cells and therefore is positive on mucin stains. The paraneoplastic syndrome associated with this subtype is hypertrophic osteoarthropathy, also known as digital clubbing. Here's an image of hypertrophic osteoarthropathy or digital clubbing. Recall that clubbing can be caused by various different cardiac and pulmonary conditions, but it most commonly occurs in lung cancer, and this occurs due to chronic hypoxemia. The next histological subtype of non-small cell lung cancer is squamous cell carcinoma. This type is highly associated with smoking and usually has a central location. On imaging, often cavitary lesions can be seen. Recall from our Step 1 pathology lectures that this tumor is characterized by keratin pearls and intercellular bridges on histological examination. Squamous cell lung carcinoma produces a protein that functions similarly to parathyroid hormone, which is called parathyroid hormone-related peptide, and this can cause hypercalcemia. Next, large cell carcinoma is a highly undifferentiated type of non-small cell lung cancer that's found peripherally and has a poor prognosis. It can secrete beta-HCG, resulting in gynecomastia, although this is relatively uncommon. Lastly, bronchial carcinoid tumor is a neuroendocrine tumor that can have a central or peripheral location. It has an indolent course and can cause symptoms of mass effect, such as wheezing. These tumors tend to have a good prognosis. Bronchial carcinoid tumors can cause carcinoid syndrome, resulting in flushing, wheezing, and diarrhea due to the release of serotonin by these cells. Note that wheezing in patients can be due to the mass effect produced by the tumor or the bronchoconstrictive effects due to the release of serotonin. The second type of lung carcinoma, small cell lung cancer, or SCLC, is more aggressive and is characterized by rapid growth and early metastasis with a poor prognosis. It's a neuroendocrine tumor that has a central location and is associated with many paraneoplastic syndromes. For example, it can secrete adrenocorticotropic hormone, or ACTH, which can cause Cushing syndrome. It can also produce antidiuretic hormone, causing syndrome of inappropriate ADH secretion, or SIADH. Patients with small cell lung cancer can develop antibodies against presynaptic calcium channels, resulting in Lambert-Eaton syndrome. All right, let's try a quick question. A 57-year-old male comes to the physician due to weakness in his shoulders and hips while trying to get up from his rocking chair. He says it takes him several attempts to be able to rise from his chair. His other complaints include a chronic cough and dry mouth that he attributes to smoking, as well as recent erectile dysfunction. He has a 40-pack-year smoking history. What is the most likely cause of this patient's condition? All right, this patient has a very long smoking history, a chronic cough, and now complains of a dry mouth, erectile dysfunction, and weakness in his proximal muscles, particularly his shoulders and hips. Lung cancer should be high on the differential. This presentation is classic for Lambert-Eaton myasthenic syndrome, which is a paraneoplastic disorder caused by small cell lung cancer. Lambert-Eaton myasthenic syndrome is caused by antibodies against presynaptic calcium channels. As we know, calcium is necessary in the presynaptic terminal in order for acetylcholine exocytosis to occur. Antibodies decrease calcium entry in the neuron, and therefore acetylcholine release is decreased, leading to muscle weakness. It mostly involves large proximal muscles, which is in contrast to myasthenia gravis, which involves small muscles such as the extraocular muscles. Lambert-Eaton myasthenic syndrome, in contrast to myasthenia gravis, is also characterized by autonomic symptoms, such as dry mouth and erectile dysfunction, and this is because acetylcholine is necessary for both saliva production and an erection. So again, the patient's condition is caused by Lambert-Eaton myasthenic syndrome, likely secondary to small cell lung cancer. All right, let's move on to risk factors. Smoking is the single most important risk factor associated with lung cancer. This includes active and passive smoking. Environmental exposures such as asbestos and radon can also predispose individuals to lung cancer development. Some types of lung cancers, such as adenocarcinoma, can be associated with mutations in the EGFR, ALK, or KRAS genes. Lung cancer often remains asymptomatic for a long time, and patients usually present late. General symptoms include a cough, hemoptysis, chest pain, dyspnea, and weight loss. More specific symptoms can be due to local invasion, compression, metastasis, or paraneoplastic syndromes caused by lung cancer. Compression of the superior vena cava can cause superior vena cava syndrome, which is a potentially life-threatening condition characterized by dyspnea, facial plethora, upper extremity edema, and distension of the superficial veins of the face, chest, and upper extremities. Here is an image of a patient with superior vena cava syndrome. Notice the significantly dilated superficial veins of the chest. Local invasion of the recurrent laryngeal nerve can cause hoarseness, and invasion of the phrenic nerve can cause diaphragmatic paralysis and dyspnea. Lung cancer arising in the superior sulcus of the apex of the lungs can cause a variety of symptoms, collectively referred to as Pancoast syndrome. They occur due to the compression of surrounding structures by the tumor. One of the high-yield manifestations of Pancoast syndrome is Horner syndrome, which occurs due to the compression of the cervical sympathetic ganglion. Here's an image of a patient with Horner syndrome. This is the normal eye, and this is the affected eye. Notice the meiosis and ptosis of the affected eye in comparison to the normal eye. Pancoast tumors can also compress the brachial plexus, resulting in shoulder pain that radiates down the arm. Recall from our Step 1 pathology lectures that superior sulcus tumors, or apical tumors, can involve the C8 and T1 to T2 nerve roots due to its close proximity to them. This leads to shoulder pain that radiates down the arm. Involvement of the pleura, usually in peripheral tumors, can lead to malignant pleural effusions. Patients can present with symptoms related to lung cancer metastasis. Most common metastatic locations include the liver, the adrenal glands, bones, and the brain. Patients can also have symptoms related to the paraneoplastic syndromes we discussed previously. Therefore, lung cancer should be on the differential if a patient presents with signs and symptoms related to those. Primary lung cancer is usually suspected in a smoker presenting with signs and symptoms of lung cancer like we just mentioned, or could also be discovered incidentally. A thorough history and physical examination should be done. Patients need to be asked about smoking status and the amount of packs consumed. Physical examination should also include neurological examination, which is very important to determine possible brain and spinal cord metastasis. Essentially though, when primary lung cancer is suspected, imaging is always performed. Chest x-rays, although less sensitive than CT scans, may show infiltrates mimicking pneumonia. For example, in adenocarcinoma, cavitations in squamous cell carcinoma, or mediastinal widening in centrally occurring tumors. A CT scan with IV contrast should be performed on all patients suspected with lung cancer. It has a higher sensitivity than chest x-rays and is used for staging and to facilitate the decision regarding the method and modality of biopsy once a lesion is identified. Laboratory evaluations, including a CBC and electrolytes, can be done. Electrolytes may show disturbances related to paraneoplastic syndromes. For example, hyponatremia can be found in small cell lung cancer, while hypercalcemia can be found in squamous cell lung cancer. Also, a liver panel including ALP, AST, and ALT can be done if liver metastasis is suspected. A transthoracic biopsy or a bronchoscopy with biopsy can then be done to confirm the diagnosis and determine the type of cancer, which will then direct treatment. Full body PET scan or MRI can be done to look for metastasis. Here is a chest x-ray of a patient with lung cancer. Even though the lesion is centrally located, the only way to determine the type is through a biopsy and histological evaluation. Non-small cell lung cancer can be surgically removed in limited disease. Adjuvant chemotherapy is added in more advanced stages. If the patient is deemed to be a non-surgical candidate, radiation therapy then becomes the mainstay of treatment. Targeted therapy for EGFR, ALK, and KRAS mutations can also be administered if such mutations are present. Small cell lung cancer, in contrast to non-small cell lung cancer, cannot be resected and is treated with chemotherapy instead. Radiotherapy can also be used alongside chemotherapy, but the specifics are beyond the scope of step 2. The most important information regarding treatment that you need to keep in mind is that non-small cell lung cancer can be surgically resected, while small cell lung cancer cannot, and is instead treated with chemotherapy. Okay, next, let's discuss solitary pulmonary nodules. With regards to solitary pulmonary nodules, we'll be discussing general information, diagnostic workup, risk assessment, and management. Let's start with some general information. A solitary pulmonary nodule refers to a well-defined solitary mass without any associated lymph node involvement. They are usually small, with a size of 30 millimeters or less, and are most commonly discovered incidentally on imaging, done for other purposes. The most important thing is to figure out whether it's of benign or malignant nature. The differential diagnosis is wide. Examples of benign etiologies include granulomas, hamartomas, and adenomas, while malignant etiologies include lung cancer, metastasis to the lungs, and carcinoid tumor. Here is a CT scan showing a solitary nodule in the lower left lobe. It can be difficult to differentiate benign and malignant nodules on imaging alone, so a more detailed assessment is needed. In order to determine whether the nodule is benign or malignant, clinical risk should first be assessed. Then imaging should be obtained, usually a CT scan, and features of the nodule should be assessed to determine the risk of malignancy. Images would need to be compared to previous ones to look for changes. Let's first discuss how clinical assessment for risk of malignancy is done. Important features to consider include the age, smoking status, and the presence of symptoms. Patients older than 35 years of age, patients who are smokers, and patients with symptoms such as hemoptysis, unexplained weight loss, or chronic cough are considered to have a high risk of malignancy. After imaging has been obtained, nodule features should be thoroughly assessed for risk of malignancy. This, in reality, requires an in-depth assessment and a detailed description. For the purposes of step 2, it's enough to know that a large size of more than 2 centimeters, as well as irregular borders, absence of calcifications, and growth in size are all features highly concerning for malignancy. Okay, moving on to management. After imaging has been obtained and a clinical assessment has been done, nodules are often classified into low, medium, or high risk. Therefore, for localized disease, management is very individualized depending on the risk assessment, which is calculated for each patient. Generally, for simplification, if a nodule has been stable and has not changed in size for 2 years or more, it's considered very likely to be benign and only warrants yearly follow-up. If a nodule is deemed high risk or is suspicious of malignancy, ultimately a biopsy or resection is warranted to confirm the diagnosis and to guide therapy. All right, let's try a question. A 39-year-old female is accidentally found to have a solitary pulmonary nodule of 1.5 centimeters on a chest X-ray. Her previous chest X-ray, performed 3 years ago, shows the solitary pulmonary nodule to be 1 centimeter. She is a non-smoker. CT scan reveals a nodule with smooth borders and no spiculations, calcifications, or lymphatic invasion. What is the best next step in the management of this patient? All right, this patient presents with an accidentally discovered solitary pulmonary nodule of 1.5 centimeters in diameter. A chest X-ray performed 3 years ago showed this nodule to be 1 centimeter. This means that the nodule is growing in size, which is why she underwent a CT scan. A CT shows the features of a benign nodule, such as smooth borders, no spiculations, calcifications, or lymphatic invasion. According to these findings, as well as her non-smoker status and a relatively slow growth of the mass, her pretest probability of having lung cancer is low. Therefore, the best next step in management of this patient is serial CT scans to track the size and features of the solitary pulmonary nodules. All right, let's take a look at our algorithm to summarize and organize some information that we just discussed. Note that the information in this algorithm is really simplified as lung cancer protocols are much more complicated. Think of this algorithm as a guide to help you focus on the bigger picture. So patients can be completely asymptomatic with a pulmonary nodule discovered incidentally on imaging, or patients can present to the physician with signs and symptoms suggestive of lung cancer. Either way, imaging like a chest X-ray should be obtained and should be compared with previous imaging. Generally speaking, lesions that are solid, have smooth borders, and are stable in size are more likely to be benign. So no further workup is needed, but follow-up may be warranted in some cases. In case imaging shows a new or enlarging lesion, or no previous images are available to compare, a CT scan with IV contrast needs to be done. Features on CT scans suspicious of malignancy include the presence of pleural effusions, cavitations, or large nodules. If a single lesion is detected, primary lung cancer is suspected and a biopsy needs to be performed to confirm the diagnosis and determine the type of cancer. Small cell lung cancers are treated with chemotherapy with or without radiation, and non-small cell lung cancers are treated mainly surgically. If multiple lesions are detected, metastatic cancer is highly suspected, and full body imaging is needed to determine the primary location. Remember that metastatic cancer is more common than primary lung tumors. Once confirmed, a combination of chemotherapy and chemoimmunotherapy can be administered. Radiation is used in case of brain metastasis. Lastly, palliative care should be considered in patients with severe advanced disease. All right, now let's move on to mediastinal masses. Here's a table that combines some of the masses that can be found in the mediastinum. The mediastinum is essentially the space between the lungs. As you may know, the mediastinum can be divided into the superior and inferior mediastinum. The inferior mediastinum can be further divided into the anterior, middle, and posterior mediastinum. Masses in each of these places can arise from and cause symptoms related to major adjacent structures. Superior mediastinum masses are not so common. Sometimes thymomas and lymphomas can be found there. Anterior mediastinal masses are important and are usually remembered with the 4 T's mnemonic. It stands for thyroid tumors, thymomas, terrible lymphomas, and teratomas. Middle mediastinal masses can include centrally located lung cancer, lymphadenopathy, aortic aneurysms, and mediastinal or diaphragmatic hernias. Neurogenic tumors, such as neuroblastoma, esophageal cancer, and lung cancer, can all present as posterior mediastinal masses. Mediastinal masses in general can be asymptomatic or cause symptoms due to compression of major structures, resulting in cough, dyspnea, hemoptysis, and chest pain. Similarly to lung cancer, mediastinal masses can affect the recurrent laryngeal nerve, the sympathetic ganglia, and the phrenic nerve, leading to hoarseness, Horner syndrome, and diaphragmatic paralysis, respectively. Here is a nice image from our partnership with Amboss that highlights several important features of the mediastinum. And from this image, we can note how the mediastinum is divided. Having this image in mind can help you remember the possible masses that could be found in each area of the mediastinum. All right, now let's move on to discuss lung cancer screening. Screening for lung cancer is done with a low-dose chest CT without IV contrast annually. Note that guidelines for lung cancer screening is different according to different organizations. In this lecture, we discuss guidelines according to the U.S. Preventative Service Task Force. All right, so which patients need lung cancer screening? Patients 55 to 80 years of age who have at least a 20-pack-year smoking history and who are current smokers or who have stopped within the past 15 years. Screening should be stopped if the patient has stopped smoking for 15 years or more, or in case of severe debilitating disease leading to a limited life expectancy. All right, let's finish up with a final multiple choice question. An 82-year-old female comes to the physician reporting increased urinary frequency. She currently uses the bathroom 8 times per day. She denies dysuria. She also noticed that she is more constipated than usual. Her past medical history includes an ischemic stroke 5 years ago, complicated with oropharyngeal dysphagia. She also suffered from a kidney stone treated with shockwave lithotripsy 6 months ago and right lower lobe pneumonia 3 weeks ago. She has been smoking 2 packs of cigarettes per day for 60 years. Physical exam shows a dehydrated woman with a flat affect. Her serum calcium is 15 and parathyroid hormone is 100. A chest x-ray reveals a left hilar cavity. Which of the following is the most likely diagnosis in this patient? A. Squamous cell carcinoma, B. Small cell lung cancer, C. Lung abscess, or D. Post-pneumonia bronchogenic cyst. All right, this patient presents with increased urinary frequency, constipation, dehydration, a flat affect, and a serum calcium of 15. Normal calcium levels are between 8.4 and 10.2, so a calcium of 15 is very high. Together, these symptoms are a classic manifestation of hypercalcemia, remembered by the mnemonic stones, bones, groans, thrones, and psychiatric overtones. This patient has an extensive smoking history, and she also has a left hilar cavity on her chest x-ray. All of these findings point towards squamous cell carcinoma of the lungs. So the correct answer here is option A, squamous cell carcinoma. Again, here is the slide that we already discussed earlier, reminding us of the paraneoplastic syndromes of different lung cancers. Let's recall that squamous cell carcinoma can produce parathyroid hormone-related peptide in a paraneoplastic manner, resulting in hypercalcemia with low parathyroid hormone levels. This patient does have low parathyroid hormone since the normal PTH range is from 230 to 630. All right, now let's talk about why the other options are incorrect. Option B, small cell lung cancer is certainly possible in this patient with an extensive smoking history and a central hilar mass on the chest X-ray. However, small cell lung cancer is characterized by paraneoplastic syndromes such as ectopic ACTH-dependent Cushing syndrome, SIADH, and Lambert-Eaton myasthenic syndrome. Small cell lung cancer has not been shown to cause parathyroid hormone-independent hypercalcemia, so B is incorrect. Option C, lung abscess, is also possible in this patient with stroke-induced oropharyngeal dysphagia and the history of recent pneumonia. However, a lung abscess usually shows air fluid levels in addition to the cavity. This patient, on the other hand, had only a cavity on chest X-ray, so C is incorrect. Option D, post-pneumonia bronchogenic cyst, is also possible in this patient with a recent history of right lower lobe pneumonia. However, a bronchogenic cyst usually appears in the lobe previously affected by pneumonia. Also, none of the above-mentioned conditions would explain hypercalcemia with low PTH levels. And this patient had the cavity on the left rather than the right hilum, so D is incorrect. And again, the correct answer is A, squamous cell carcinoma. And that concludes our lecture on lung neoplasms.